Okay, thank you everyone for coming here today. Let me just get this into presenter mode so you can see. I'm Laura Penton Reader. Oops, what is that? I'm sorry, everyone. I'm not feeling very well on top of this tech problem. Okay. Welcome today for our community-based doula info session. I'm Laura Penton Reader. I'm the Perinatal and Early Childhood Health Integration Manager at Vermont Department of Health and Family and Child Health. And I'm joined today by Catherine Wolf, Maria Rossi, and also Margaret Walsh from NCSS. We're here to talk about a doula overview, doula programming that exists currently at DAs, different iterations of doula programs in Vermont, community-based doula programs in Vermont at this point. We'll talk to you a little bit about our understanding of S109, which is the potential Medicaid reimbursement for doulas. We'll talk to you about the Perinatal CARES work plan and how community-based doulas fit into that effort. That is a 4-year grant from HRSA at Family and Child Health. And then finally, we'll wrap up by discussing our request for proposal process for designated mental health agencies or potentially other community partners who are interested in implementing community-based doula services. I think I'll hand it over to Catherine.
Thank you. Good morning, and thank you everyone for joining us today. I just wanted to say a huge thank you to Margaret and Maria for sharing their invaluable perspective on the doula programming work at both Washington County and NCSS. I do know that we have a lot of information to get through this hour, and we want to leave ample time for questions. So I just wanted to invite you to, if you'd like to pop your name and agency position in the chat box, just in order for us all to have a sense of who's coming together this morning, rather than doing formal introductions. I recognize this group's very familiar with the countless benefits of doula supports to families during the perinatal period, but I just wanted to acknowledge here why doula care is so vital to our perinatal mental health system of care. Can you go back a slide, Laura? Sorry.
Yeah. Oops, does this change your view?
It does. It's not in show mode anymore. That's okay.
Let me... It's just I can't see anything else other than the slides okay. Sorry, this laptop is flummoxing me. I apologize. Okay.
No worries.
Is that what you were looking for?
Perfect. Thank you. Yeah, so we just wanted to acknowledge the unique role that doulas provide during the perinatal period, and improved outcomes that we are aware of. Just a snapshot of what we know: lower rates of medical interventions, higher rates of APGAR scores, overall greater satisfaction with one's birth experience. And there's new research drawing attention to the impacts of doula care on perinatal mental health, suggesting that doula support can reduce rates of depression and anxiety in the postpartum period. It's also no secret that the U.S. has disturbing rates of disparities across perinatal health and mental health outcomes for birthing people of color. And by providing culturally safe and congruent care and advocacy that's tailored to the unique needs of pregnant and postpartum people, doulas can be one resource to help mitigate racial and socioeconomic disparities. So we wanted to acknowledge those benefits, and also the added benefit of the doula relationship across the duration of the perinatal period, to help promote continuity of care and that trust building that can happen, and then help facilitate referrals or warm handoffs to additional resources and services across the system. Next slide, please. For greater context, just looking back, STAMP was a 5-year cooperative agreement under HRSA that supported Vermont in knitting together the perinatal mental health system of care, while also increasing capacity of providers to screen and treat PMADs. Of note, STAMP was able to engage all 10 designated mental health agencies across the state and Vermont gained momentum around implementing some innovative strategies to better support pregnant and postpartum people, with doula care being one of them within the designated agency system. Next slide, please, Laura. And then fast forward, a notice of funding opportunity was released in the spring of 2023 for another round of HRSA funding. This time it was titled Screening and Treatment for Maternal Mental Health and Substance Use Disorders. The funding amount was to be less than with STAMP due to the allowable allocation based on population size. Vermont's application last spring therefore needed to narrow the scope and identified community level doula programming as a focal point in the work plan. As you are probably aware, VDH was originally notified last September that Vermont was not selected as one of the states to receive the additional 5 years of competitive funding. But then back in mid-May of this year, HRSA contacted VDH to report that additional funds were appropriated by Congress and that in fact Vermont would be a recipient of the funding for a period of starting June 1st, 2024 through September 30th of 2028. All that's to say that the funding timeline for perinatal cares is now 4 years and 4 months. And despite this timeline being shorter than expected and the funding being less than with STAMP, there's hope of expanding what is offered at the existing doula programs and then simultaneously starting up at 3 new sites. With the Medicaid reimbursement pursuit underway for the doula profession, funds are intended to also help support activities to assist the doula community with that process at hand, while supporting Washington County and NCSS in the development of training competencies and a training series. Examining also the workforce needs of the doula community and much more that I'm sure Maria will share more about shortly. Next slide, please. And I'm going to hand things off to Maria Rossi.
Hi, good morning. Thank you guys, everyone for coming and for listening today. I think you can go on to the next slide, Laura. So my name is Maria Rossi, and since 2014, I've been I've been working at Washington County Mental Health for 20 years, but in 2014, myself and a few others started the Doula Project. We provide prenatal birth and postpartum support to folks who receive Medicaid assistance and qualify for community mental health services and live in our Washington County catchment area. We get our referrals primarily from community partners, really heavily from CDMC. And here are some of the services that we provide. I sort of think of this as intensive doula support. We provide case management, childbirth education, parent prep, birth and postpartum doula support with a heavy focus on the social risks that you see here, which most of the clients that Washington County is serving across the board have some combination of these social risks and at varying degrees, but they all qualify for mental health services. You can go on to the next slide. So this is sort of our model versus a sort of traditional or typical doula model. And you can see that in our community doula model that we are providing much more intensive supports. And that's not to say that it is better than a typical model, it's just a different set of needs. And we are serving a higher needs population, so this more intensive support does make sense. We don't have a limit to the number of prenatal or postpartum visits. We have someone available at any point. We do operate in an on-call system, and we do have someone available at any point in pregnancy, which is especially important because of all sorts of medical and social risks. We do have folks who are more at risk for preterm labor, and so having someone available at any point is really important. We have specialized trainings which have been determined by Washington County, and as well as clinical supervision with our licensed social worker, which for anybody who works in a designated agency, you know, that is something that everybody has access to. So it's not really unique to the doula project, but it is different. I mean, it's not really unique to the doula project in Washington County, but it is unique to doulas in general. We provide case management, and because we're embedded in a designated agency, we do have easier access to all sorts of supports that lie within a designated agency: therapy, group support, psychiatric supports. We have Washington County has many different wellness initiatives that folks can access. Some of them have been within the doula project, and many of them have been outside that and are offered to the agency as a whole. You can go ahead, Catherine, to the next slide. Laura, sorry.
Oh, I'm sorry.
And here is the definition of community-based doulas. I won't read the whole thing. Everybody can go ahead and read that. But it really does talk about expanding on, it does use the word traditional. I struggle with that word because traditional doula to me means something else. But what we see as sort of typical and a more business model often of care versus a community doula serving generally folks with higher levels of need. You can go ahead to the next slide, Laura. And here are some examples. This is not a complete list, but these are some examples of the various trainings that our doulas currently have. And this has been evolving over a decade, so we've done many more than this, but this is some most current examples. And as you can see, many of the examples are really focused in trauma and social determinants of health, in those risk factors.
Do you want the next slide?
Yeah, thanks. And one of the things that we did today was to kind of go through some different staffing structures and considerations. And the reason is that we were hoping that people really think creatively about how to implement doula programming within their agency. You know, right now at Washington County, we have 4 staff, myself, and we have full-time case managers. But this has been 10 years. We have the most, I would say, the richest that we've ever had before. So we're really like a decade in, and that's very different than where we started. So we've had many different iterations. Some have worked better than others, of course, but wanting people to think about ways that they could creatively staff a program in their particular agency. And sometimes some of that might be things that you already have available. But these are some of the considerations. Clinical support staff is, of course, necessary if you're in a designated agency. And I think that from the doulas on staff that we have who have worked outside sort of in the community as doulas outside of Washington County, this has actually been the feedback that we have gotten the most as one of the most helpful things to them, is to be meeting regularly with a social worker who is familiar with perinatal mental health, and to be going over cases, especially ones that are especially complicated or challenging for them. And that happens in a number of ways, as one of the things that they have found most supportive. So I really encourage people to think about that. A coordinator, somebody to coordinate things like trainings, mentorships. When are you going to have meetings? How are you going to address an on-call? There's lots of different ways to do that. Accepting referrals, kind of be a point person. And that could be somebody who is also, ideally it is somebody who is a doula, because a lot of those things do, I think, lend itself to that lens. And they don't necessarily need to be doing all of the work. Like it could be somebody separate from that. It could be some part-time, full-time, depending on your own needs and financial feasibility. There may be a staff person that is already at your agency who has a special interest of this, and of course has the availability, but to take on a little bit of different or extra additional work. And I think in a lot of ways, that is ideal because you have somebody who already understands the system and knows what's available in an agency to access, but also what's available in the community to access. And having a familiar person is often really helpful when you're talking about community as a community liaison. And then we have either full-time or part-time case managers who are doulas, and maybe additional doulas in the community who are contracted to do work as needed. It may also be mentees that you work with who have been kind of assigned to a doula as a mentee. And here are some other considerations. Some other programs would also benefit from identified staff responsible for data collection and interpreting that data, to grant writing, childbirth education programming. And of course, there are other specialties that could be added here. And these may be things that are already accessible to you, such as a grant writer or a data collection within your agency. You can go ahead to the next slide, Laura. Here are some examples. This is not, again, an exhaustive list of examples. It's just some examples to kind of get people thinking outside the box a little bit and thinking creatively. One would be a coordinator and doulas as independent contractors paid with grant money. Benefits of this is that you could serve a lot of people or a broader population, and maybe not a lot, but broader. And there's money savings on costs related to having and hiring employees. This does pose a lot of challenges in that as a designated agency, if you're not opening up participants as clients, you're not drawing down on your per member per month numbers. And so that's actually like a loss potentially, depending on what's going on with you, but it's potentially a financial loss. It's much harder to require trainings, specialty trainings of doulas who are acting as independent contractors versus those who are employees, and which can result in a lack of continuity, communication challenges because people aren't necessarily employees, and also less support for doulas in terms of on-call, sharing call, backing each other up, all of those things. And I would say there's also a risk involved here in that as an independent contractor, anybody at any point can pull out, their life changes or they decide they don't want to, whatever happens. And of course, anybody can leave a job as well, but there is a layer of it being a lot easier if you're an independent contractor. And so in some situations, that might be less reliable. You can go to the next slide, Laura. Another example might be a doula coordinator. And then maybe there's people who already exist in your agency who are interested in doing doula work. Of course, that means that they would need to have approval by their supervisor and their programs. So we'll just take that as it is. But there are some benefits in terms of hiring costs associated to having employees. That's already being covered. They also have probably a pre-existing understanding of populations and a comfort working with a higher needs population. All the participants are considered agency clients, so there is that benefit, and it's much easier for doulas to share responsibilities on call and otherwise. The challenges, of course, would be that we could likely only serve few pregnant people at a time because of competing interests when working for different programs within an agency. And then, when people are doing many different jobs, it can contribute to burnout, overwhelm, overworking, which can also be risky in terms of retention. And then, of course, there's increased coordinating responsibilities. Of course, the bigger a program gets, the more responsibilities are going to fall on the coordinator. Go to the next slide, Laura. Here's another one. This is where I would say we are kind of at right now, but I think we're probably at the next one as well. But a doula coordinator, some combination of full-time, part-time staff. I would say this is probably one of the examples that has the most ability to bring in new clients because there's more availability of the staff, and greater opportunities and richer ways to serve those clients with case management, community support, care coordination. The larger the doula group, the less pressure there is on the on-call system, however you set it up. And anybody who has worked on call will tell you it's very difficult to be on call. And the more flexibility and less pressure on that on-call system, the better for everybody. And then when people are agency employees, it's much easier to require certain trainings, require a certain level of supervision. Trainings as a group is really lovely in terms of, just group dynamics and camaraderie. And I think you can bring a much deeper understanding when you train as a group. It, of course, is more costly. Hiring is not easy. We all know there's workforce shortages in our state, and doula shortages are no exception to that. It also takes a kind of specific sort of person who is open to doing this work, serving a higher needs population, and willing to be on call. There's like a lot of layers to that, that just because somebody is a doula, they may not necessarily be wanting to do this sort of doula work. And if somebody is really great at doing a case management piece, they may not really be apt at doing doula or on-call work. You can go to the next slide, Laura. And I think this is Margaret.
Thanks, Maria. Hi, everyone. I am Margaret Walsh. I'm the Parent-Child Center Director here at NCSS. And I have been a part of the HEART program since its inception many years ago. It started small and has grown thanks to lots of different funding sources, STAMP being one of those. So I can just give a little bit of an overview on what the program is, a little history, and what it looks like today. So the HEART program began originally as a one and a half position that was really focused on mitigating the risk for clients in our area that are at risk for postpartum mood and anxiety disorders, or we identified as at risk. They were either already clients of the agency or were receiving home health services, and we were just noticing that families were really struggling and they needed some additional targeted support. So from there, we gave it a name, gave it the HEART program name, and with support from different funding sources. I'm a parent-child center within a designated mental health agency, which is really different than a lot of the other DAs. So we do have that advantage in that funding source of parent-child center integrated grant funding. So we were able to support not only one perinatal mental health clinician, but take on another. So there was 2 perinatal mental health clinicians, and then we expanded to postpartum doula supports. So we now have 3 postpartum doulas and 2 perinatal mental health clinicians, and they are supervised by a licensed clinical mental health counselor. And I'm also a licensed clinical mental health counselor. So that is also an advantage of being part of a DA, that you have that sort of built in already if that's a need or a want. So our program looks a little bit different in that we don't support the on-call or the birthing aspect at all. We say perinatal because we serve families in the perinatal pregnancy and postpartum period. So as Maria mentioned, they offer maybe 1 postpartum visit, and we offer up to 1 year of postpartum visits. So it's really more that pregnancy following them through the postpartum period. So that Maria already went through sort of what that community doula piece looks like. We often get our referrals through the hospital. We actually have a person, an identified perinatal family support specialist who sits at the hospital and helps us connect with families who are there, which is a wonderful resource, who are in pregnancy. And then they are made referrals to us through our integrated coordinated system of referrals through a DA, which is also a benefit. We also get referrals through pediatricians' offices. We get referrals through DCF. We get a lot of self referrals now because of word of mouth. So because it's grant funded through not necessarily a Medicaid only funding stream, our program is universal in that we can see all families, which is wonderful. We see families who are eligible for Medicaid, but we can also see families who have private insurance. And again, that's because we have access to these different funding streams. But because we're Parent-Child Center embedded within a DA, we often see a lot of referrals coming through for families that are Medicaid eligible. So that is a bulk of the folks that we see. So like I said, we have postpartum doulas who see families in pregnancy and then they give birth and we follow them up through 1 year. The perinatal mental health clinicians can see them up to, I think it's up to 2 years now. Just looked at the research and found that that was sort of what was needed. But the families who receive doula services have access to an array of supports beyond the home visiting supports that they have access to, which is, I won't say an unlimited number of visits. I think it's really based on capacity and caseload size, but they do have at least, in pregnancy, 1 to 2 home visits as they sort of get closer to giving birth. And then after that, it's sort of as needed and what the family needs. And I say family because it can be the mom, but it's also the non-birthing partner. And we make sure to sort of wrap the family in a person-centered approach. So that's been really, really critical to the service. So some other pieces of the HEART program that are not just connected to the home visiting are access to concrete supports. So we have diapers and wipes and formula and access to gas cards and all the things that families need who might be socially at risk or are vulnerable, or maybe they're not. Maybe they just need access to some of those supports. We have things like safe sleep kits, so lots of access to concrete supports for all the families we serve. We offer support groups, so our team just recently launched a I can't remember what it's called, the Baby and Me yoga class, I think is what we named it, and a pregnancy circle. So based on the need of our community, we're able to offer these groups free of charge to families. They don't have to be engaged in this program or enrolled necessarily, but they can access it if they are pregnant or are seeking services in our catchment area. The grief and loss support has been really critical. Any family who's experienced a loss, it could be an early loss, it could be a late-term loss, it could be a stillborn situation in the hospital, will get a call, and we are sort of the point person and point contact for families who have experienced loss in our region, which is wonderful because the hospital and folks know exactly who to call. It's been great to be able to connect to families sometimes right when they're in the hospital if they've had the loss or immediately after. So we have a weighted bear program that we offer families who have experienced loss, and we put the bears, well, I don't, but my team puts together the bears to a desired weight that the family wants, and then they deliver those. We also have miscarriage kits that we partner with Empty Arms to deliver to families. So that's been sort of an invaluable resource. And the rapid access mental health clinician, we're working on implementing with some of the funding that is available to us. And then I'll just quickly go into the Heart to Heart program. That's an Abenaki specific program that population is served through 2 community health workers that are Abenaki themselves. And so they work with those families and are getting trained in I think Kappa Doula and some of the other trainings that we follow in our program. Postpartum Support International as well. And the last bullet is just around a lot of what we do is just providing information, parent ed, childbirth ed, making referrals, and connection to community resources. Thanks. Next slide.
I think this is me. Is this correct?
Yeah,
Okay.
thanks, Maria.
I can't see the numbers of the slides, so
I know, I'm
getting
sorry,
a
I don't know
little
where they
lost.
are.
No, it's okay. It's totally fine. As we were talking in the beginning, I think most of you know that there is Medicaid coverage for doula care is being advocated for and was advocated for and has been for many years in the legislature. I was a part of the first bill many years ago, which sort of sat and didn't really go anywhere, which was probably great because we've learned a lot in the time since, and I think we would have probably mucked it up had it passed then. But in the last few years, as doula services have become, more have really been seen as like a mitigation for all sorts of birth outcomes. You probably know many states around the country have passed Medicaid coverage for doula care, and in some cases, private insurance as well. So where it stands right now is that in the legislative session last year, legislature directed the Office of Professional Regulation and the Department of Health Access, which is Medicaid in Vermont, to undertake their individual reviews of doula services and costs. OPR, I think you can go to the next slide, Laura. Thank you. So OPR, for anybody who isn't aware, is the overseeing agency under the Secretary of State that oversees many different professions in Vermont, everything from I'm a social worker as well, so I'm also under OPR in that way, but early childhood, different early childhood professions, contractors, massage therapists. It's really like the whole gamut of professions. And these are the different options that they have for oversight and regulation. There's registration, which means everybody who's part of that profession has to register. There's certification, meaning that there's a certain certification that they come up with that's voluntary. The people, if they want to participate, become certified. And then there's licensure, which is the most sort of intensive. Each pathway does have fees attached. So the Sunrise study that OPR was directed to conduct means that OPR is studying what is the risk to the public, what is happening in other states. They had a public feedback forum a couple of weeks ago, and they make a recommendation based on findings. Where we are right now with OPR is they're putting together the final part of their Sunrise study that will be presented to the legislature in the new session in January. We can't say for certain because we're not OPR, but having been really closely involved in the process, what we're thinking is going to happen is that OPR will probably land on certification, which means that doulas who want to participate in Medicaid coverage would have to be certified under OPR. That does not mean that everybody who is certified under varying other organizations would automatically be certified. It means that OPR would come up with a list of competencies and would review whether or not those certifications met the competencies. And some of them may, and some of them may not. And so DEVA, which is Vermont Medicaid, is doing their own thing, the cost benefit analysis of coverage, determining a pay rate and structure for coverage, and will give a recommendation whether or not it goes in our state budget. And so DEVA is in the process of doing that. And likewise, they're looking at what's happening in other states. I think they're focusing probably on what's happening in states closest to us. So places like New Hampshire, or sorry, not New Hampshire, Massachusetts, and New York, Rhode Island, New Jersey all have doula programming now. And it looks a little different for each one. But I think that they generally look at states that are closest to us in terms of like cost of living and population to determine these things. So DEVA, we'll see. Their process does not have to be as transparent as OPR's. So we'll see what it is that comes from that. So you can go to the next slide, Laura. So the timeline, us learning about this has been like in real time. A lot of these things are new to all of us who are participating in this process. But we do know that they need to present their findings in January of this coming January, the new legislative session. and sorry, I'm just, there's so much to this. I'm trying to make sure I don't overwhelm with information. And if, assuming that everything moves forward, when the budget, if and when the budget passes in May, there will be another process with OPR, which will determine sort of like the nuts and bolts, and that's called a rulemaking process. So that will determine what are competencies, what is the scope, what is the standard of care, those kinds of things. And we've been told that will take another 6 to 9 months, and so up to a year. And given that that's like the budget for the state, what we anticipate is that if all of this goes through, that it will go into effect in July of 2026. It's all ultimately up to the legislative process. It's all estimated timelines. There remains no guarantees that this will happen. I think we are cautiously optimistic and know there's a lot we don't have say in or control over. You can go to the next slide. Part of, there's been a couple of different grants. We've gotten a Building Bright Futures grant as well as part of the VDH grant to start a Doula Association of Vermont. So that has been underway. There's identified leaders in that group right now. We just finished getting a website up and are working on recruiting doulas to join the association. And the Doula Association will be assisting with legislative efforts, as well as coming up with their own sort of code of ethics for doula care in the state. Anybody who is a doula or aspires to be a doula, is planning on being a doula, is welcome to join the association. And you'll expect to hear a lot more from it in coming months. The Doula Association came to be because those of us who have been working on Medicaid coverage have been consulting with national folks. Health One Connect is one, and there is a reproductive law firm out of California that's been assisting states in Medicaid coverage. Many of you have probably been on different calls with them, and having a statewide association really was one of the strongest recommendations from the national folks. So that's how this came to be. And you can go ahead to the next slide. And I think this is.
Yeah, I can jump in now. Thanks, Maria. Thanks, Margaret.
Sure.
This is kind of just like a summary of what we've already discussed, but I did just want to point out here at the bottom, because VDH will be reporting data on this work to our federal funders, we anticipate that we will be providing some data collection tools to those funded regions, and that would be in partnership with the lead evaluator from the Center for Behavioral Health Integration. So they'll be assisting with that effort. Next slide, please. Okay, so there was a focus in the notice of funding opportunity around health equity for this funding. So therefore, we, VDH called out certain areas of priority in the application, including what you see here. BIPOC communities, rural regions of Vermont, areas of low socioeconomic status, and health provider shortage areas. So as we consider where to get started with the new doula programs, these high areas of need will be taken into consideration as they were named in the application. Next slide, please. Okay, so we've come to learn that there are certain ingredients in a community that appear to really support or progress this work based on other regions' experiences. Listed here are some of the partners that have been identified as key pieces of the puzzle to help set other programs up for success. I'm sure Maria has a lot of thoughts on this to speak to when we get to the Q&A section, but I just wanted to acknowledge here, these are some of the key partners that are believed to really enhance this work at the community level. Next slide, please.
Hey,
Where
everyone.
to begin?
Oh, sorry.
Oh, go. Do you want to take it from here, Laura?
Yeah, I'm happy to, unless you want to.
Thank you.
Thanks, everyone. I'm going to go through this rather quickly to make sure we have some time for questions. So first of all, we just want to be clear that we are not expecting people to field a Washington County mental health level of a doula program on day one, or a heart doula program on day one. We realize that the best chance of having a sustainable program is that you can start small and that you can work with us, Maria and Margaret, for consultation and technical assistance all along the way, from design to growing to fielding additional resources, whatever you need. We wanted to find a fair process for doing proposals because we realize that there are only 3 sites available at this time. And we want to make sure that all the designated mental health agencies, or if the DA is not applying, another community agency in your area have an equal shot at applying for the funding. So we are releasing a request for proposal. We are basing this community-based doula program on what has been successful at Hart and Washington County. And if the DA can't or doesn't feel that this is the right time to apply, another community-based organization such as a parent-child center or similar can apply to host the community-based doula program. But we would want to make sure that they had communicated with their DA in advance about that. So our RFP, we're expecting to release it at the end of this week, hopefully. And I just want to give you a few highlights of what we're hoping it will include. We want to know, like, what do you want to do? How do you want to implement doula services in your community? Where would your community-based doula program be hosted? At the DA, or are you attempting to field it with a different lead agency? As Catherine mentioned before, the funding is really focused on serving BIPOC individuals because we know that they experience higher rates of maternal morbidity and mortality, as well as higher rates of PMADs and other health-related social needs. And we'd like to focus on making sure that they have access to these resources. We also are looking for health provider shortage areas and people who serve low SES populations. We'd like to know what your strategy is to engage partners in your region. I know the previous slide did list a bunch of partners that we'd like to hear from you about how you are partnering with them already or how you will partner with them. Given the quick turnaround on this request for proposal, we recognize you may not have this all sorted out, but even a list of those that you plan to reach out to as part of your implementation and needs assessment process would be great. And just noting which ones you already have a relationship with and have talked to about this doula program and those that still need to be reached out to would be super helpful. If you have a program structure in mind, for instance, if you know that you want to start with just prenatal doula services or just postpartum services, and then you're going to add birth and prenatal or vice versa, that would be great. Like, where are you going to start and where do you hope to possibly end up eventually with a few years would be awesome to know about. And we will not hold you to that. So if it takes you longer to get where you want to go, or if over time you end up shrinking or growing your proposed PAN, we're here to work with you on that. But we'd love to hear like what your vision is. Is your lead agency identified currently able to bill Medicaid? If it's a DA, we know that's a yes. We know some parent-child centers can bill Medicaid, some can't. If there are some restrictions on what you can and can't do, it would be great to hear about that. I want to be really clear that if your agency can't bill Medicaid right now, that's not going to necessarily count against you in your proposal. We understand that people are coming into this at all different levels of doula services, support for families, and Medicaid billing. However, we do hope that the agency, if they don't bill Medicaid now, there is an expectation that you would be willing to work with us toward Medicaid billing, because the hope with these community-based doula services is that they will bill Medicaid once the Office of Professional Regulation and DIVA make determinations about Medicaid billing. If on the off chance that you were an agency that doesn't bill Medicaid and you worked with us on this because you expected to bill Medicaid, but if something were to go differently and at the end of a first planning year, you ended up deciding you couldn't bill Medicaid after all, we wouldn't be upset and we would not ask for the money back. I want to be really clear there. But we really are hoping that the program ends up living at an agency for the long haul, at a agency that can bill Medicaid if we do get Medicaid reimbursement for this program. So if you have questions about that, please reach out to me and Catherine, and we can talk through that piece of it. But it's not required in order to apply. We'd like a proposed line item budget to the best of your ability. We'll work with you on that as well. And please include any questions that you have for us, and especially anything that you need answered ASAP. If you'd like to brainstorm or you have questions you want to work out, please reach out to me and Catherine. We're happy to talk through anything with you. You can also reach out to Maria if you have questions. 2 or all 3 of us is probably your best bet. We're anticipating that the RFP will be due in January. We may have adjusted that 1-3 date, Catherine. Didn't we say maybe the 15th after all? We'll look into that. And then because we realized the holiday is tight and we wanted to be a little bit more forgiving for people. And then please send your RFP to Catherine and me, and then we will bring questions to Maria as well if we have them. I just wanted to quickly say that the Maternal Health Innovation Grant, which came through Family and Child Health as of October 1st, is really exciting, and it does have an opportunity for regional perinatal quality collaborative projects. There'll be more about this coming in the next year and possibly next 6 months. And there's going to be the potential to utilize some of this funding to invest in community-led projects, of which community-based doula projects would be allowable, but the details of the MHI Perinatal Quality Collaborative Regional projects are still just in the beginning stages. So there is more to come on this. I am only mentioning it now just to be clear that there is potential for other ways to fund community-based doula programs if your RFP is not accepted at this time for this particular funding. And FCH is continuing to seek out more funding opportunities for community-based doula projects for programs that may not be chosen this time, because we know that there's a lot of interest. Questions? I'm just gonna switch to this so that. Can you still see my slides?
Yeah, we can see
Yes.
Okay. I can't see the people. So if there are questions, and if Catherine could call on, that'd be awesome.
If it's
Any
okay, I
questions?
wanted to sort of put a plug in as well, is that I know some people might be thinking as they're thinking about this, about training for doula, either existing doulas or people who want to become doulas, and that can be a really costly thing depending on how many people. And myself, Washington County and NCSS is actually putting together a training that will be free, offered around the state in the spring. So you'll hear more about that for sure, but I just wanted to let you know that there is a free doula training coming that will happen sometime March or April, and will be like an 8-week doula training.
Thank you, Maria. That's super important. Yes, there are plans for that one. We also hope that we would be able to do it again, but we are still sort of trying to set those systems in place, and figuring out the details of the training so that it doesn't, how that's going to work kind of ongoing for sustainability. I also should have mentioned that in thinking about your budgets, spending money to train doulas through other paid doula trainings is also an option. We realize that especially in the first year, you may have to do a lot of work to get doulas trained in your community to be community-based doulas. And in addition to Maria's training that she's talking about this spring, we can get some technical assistance from Maria and Margaret to help us identify other trainings that your doulas should do to be community-based doulas, like perinatal mood and anxiety disorder training, training on trauma, training on health-related social needs, and things like that if they don't already have them through other venues. So we can work with you on that. And we realize that some of the infrastructure building in year one, year one especially, and then ongoing, we'll have to spend time on infrastructure building for your program. We don't expect anybody to be able to, on day one of their grant, be able to like stand up a community-based doula program. But if you can, that's great. But just to be clear, like we recognize day one, there's going to be a lot of infrastructure building, training needs, pulling community partners together, doing some needs assessments in your communities if you feel like you need them, things like that. Are there any other questions? Well, we really encourage you, once we send out the RFP, to reach out to us and ask questions and talk through any of your pieces of your proposal that you're thinking about. I also just wanted to say one last thing, which is that there's going to be a lot of pieces of your proposal that you maybe have questions about, can't answer, only have broad strokes, and that's absolutely fine. That's what we are expecting from you, so please don't panic about that. Bullet points are fine. Small sentences and paragraphs are fine. We recognize the quick turnaround of this, and we're not expecting a beautiful, 10-page or more proposal. We really just want you to do your best with the time that you have to pull it together and the information that you have available to you. And if you really just focus on building up those partnerships, identifying what you would ideally like to do as a proposed doula, community-based doula plan, identifying a broad strokes budget, and identifying some of the infrastructure building, training needs, things like that, then you'll be in great shape, and a list of questions for us too. But please come to us during your writing process with questions so that we can help you work through them. I want to make sure that you feel like you have access to us to help you.
Yeah, I'll just say this has been a lot. This is a lot of information, a lot to digest. So please, don't hesitate to reach out if any questions come up. And I will be sending along the recording and the slides as well for everyone who is invited to this group.
Oh, and when we send out the request for proposal, you are welcome to share it with your other partners, especially if you're a region that has decided that the DA cannot support this work. Please share it with your other perinatal and early childhood partners in your community. But make sure, if you are a non-DA agency that wants to apply for this, that you've connected with your DA to check if they are applying for this funding. And if they are, then please work in tandem with the DA on the application. Thank you. And just follow up with questions. Thanks a lot, everyone.